Okay, your dah ready dah semua? Year 5
Dah. Yes, Dato.
No, Alisa binti Ibrahim
So should I start now, Doctor?
Okay. Okay. Start.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So let's begin our session with the Furqan Al-Fatihah. Okay. Good morning, Dato Dr. Fadzil and my fellow friends. So I will present the first topic regarding the chronic diarrhea in children. Okay, next. So this is the outline for my presentation. Okay, next. So we move on for the first outline, which is the definitions of the chronic diarrhea. So according to the PITS protocol, the chronic diarrhea is the episode of the diarrhea that begins acutely and lasts for 14 days or more. And according to the Nelson, chronic diarrhea can be defined as the stool volume of more than 10 gram per kilogram per day in toddlers or infants. However, in older children, the stool volume more than 200 grams per day, and that lasts for more than 14 days. The diarrhea can also be defined according to the WHO as the passage of the 3 or more stools of liquid stools per day, or more frequent passage that is more than the normal for the individuals. However, according to some resources, such as up to date, the chronic diarrhea is the diarrhea that lasting greater than 4 weeks. And according to them, persistent diarrhea is the one that the diarrhea that lasts for 14 days, and the chronic diarrhea is the diarrhea that lasts for more than a month. Okay, next. So there are a few mechanisms of the diarrhea, and the main mechanism, and there are 4 main mechanisms of the chronic diarrhea, which are the osmotic, secretory, motility, and also the inflammatory. Okay, next. Okay, so for the osmotic diarrhea, also known as diet-induced diarrhea, it occurs due to the presence of the non-absorbable nutrients in the intestinal lumen, and it causes the water retention. So it is differ from the secretory diarrhea because the osmotic diarrhea is the nutrients are not absorbed and it pulls water into the intestinal lumen. So it occurs due to ingestions of the poorly absorbed substrates or when there is malabsorptions. So the causes that can cause osmotic diarrhea are the functional diarrhea, or also known as the toddler diarrhea, when the child ingests magnesium, phosphate, and sulfate, or when there is lactose intolerance. Okay, next. For the secretory diarrhea, it occurs when there is increase in water and electrolyte secretion, and there is reduced reabsorptions of the water. So it occurs due to the presence of the bacterial toxins such as Vibrio cholera, in which they can release the enterotoxin that can cause massive secretions of the chloride and also the water. And when there is presence of the usage of the some laxative or hormone secreted by certain types of the tumor, such as bipoma, that can that can release vasoactive intestinal peptide, and when there is usage of some drugs that can cause the secretory diarrhea. Okay, next.
Semula pergi balik semula. That work jap. Okay. Okay, sini. Okay. Okay. Forward.
I'm sorry, doctor, I can't hear you.
Okay, forward. Okay lah. Continue.
Oh, okay.
Continue.
So, for the diarrhea that can caused by the motility disturbance. So for the motility disturbance, it can occur due to hypomotility or hypermotility. So for hypomotility, it can cause delay in the intestinal transport and can cause the stasis of the feces. And the stasis of the feces can cause bacterial overgrowth. But for the hypermotility, it can accelerate the transit time and decrease the absorption of the nutrient. So when there is decrease in the absorption of the nutrient, it will increase in the volume of the stools to the colon. So the causes that can cause the motility disturbance, such as the Hirschsprung disease, chronic intestinal pseudo-obstructions, or it can also occur due to secondary to extraintestinal disorders, such as the hypothyroid or scleroderma. So the characteristic for the diarrhea that occur due to the motility disturbance, it usually frequent, loose or watery stool, and urgency. However, for the inflammatory diarrhea, it occurs due to disruption at the epithelium of the intestine. So the disruption can cause the exudation of the serum and blood into the lumen. And the inflammation can widespread the destructions of the absorptive epithelium. For example, it occurs in diverticulitis, inflammatory bowel disease, infectious disease, and neoplasia. So the characteristic for the inflammatory diarrhea, it usually frequent but in small volume, and usually it's bloody diarrhea, and accompanied by tenesmus, fever, or severe abdominal pain due to the inflammation. Okay, next. So these are the table for the differences between the osmotic, secretory, and inflammatory. So the most important one for the osmotic, the differences between the osmotic and the secretory, the osmotic can be reduced, the diarrhea of the osmotic can be reduced when the patient fasting. However, for the secretory, the diarrhea would not stop even the patient is fasting. Okay, next. So move on to the second outline, approach to the chronic diarrhea. So first thing first, that we need to take the history. So for the history of the chronic diarrhea, we need to know regarding the onsets of the diarrhea itself. So for the neonatal onset, usually occur due to congenital diarrhea. If the abrupt onset, we can presume that it occurred due to infection. And for the functional diarrhea, the onset of the diarrhea usually gradually. And for the celiac disease, the diarrhea occur after introductions of the gluten-containing food, such as the wheat and rye. And for the diarrhea with temporal relationship of eating food, usually occur due to the lactose intolerance. And for the stool characteristic, if there is the bloody diarrhea, it occurs due to dietary protein intolerance or inflammatory bowel disease. And if the stool is tan colored, usually occur due to the celiac disease due to absence of the bile. Okay, next. So we also need to ask more regarding the associated symptoms. So if the diarrhea associated with the fever, it usually occur due to the infection. And if patient complain for abdominal pain, we can try to rule out the obstructions, irritable bowel disease, irritable bowel syndrome, or inflammatory bowel disease. And when there is excessive lactose occurs due to the carbohydrate malabsorptions, If the leakage of the stool, it occurs due to the fecal incontinence, and if the patient experience failure to thrive or weight loss, it occurs due to malabsorption, pancreatic exocrine insufficiency, or anorexia nervosa. And we also need to ask more regarding the systemic symptoms to rule out any hypothyroidism and scleroderma. Okay, for the past medical history, we need to ask regarding the underlying medical conditions such as HIV, immunoglobulin deficiency, cystic fibrosis, celiac disease, hypothyroidism, and also inflammatory bowel disease. And is there any previous therapeutic intervention done to rule out any side effect of the drug, radiation enteritis, and also the pseudomembranous colitis? Okay. Okay, so move on to the next history that we should ask is the nutritional history. So we need to ask the parents whether the child is fully breastfed or using formula milk. So if the patient the children is exclusively breastfed, it can be protective mechanism against the enteric infection. But if the children use formula feeding, we need to ask regarding the hygiene of the bottle, the preparations of the milk. So, and we also need to ask regarding any intake of the sugar-free food, excessive juice, milk or lactose-containing food, and sucrose or starch-containing food. And for the family history, we need to ask any history of heritable disease such as inflammatory bowel disease and also the celiac disease. And for the social history, we need to ask regarding the housing condition, the hygiene, water supply, and also the sewage disposal. Okay, next. So after completing us regarding the history, we need to do a physical examination. So for the general examination, we need to look for the growth chart to look for any failure to thrive. We need to assess the hydration and nutritional status, look for vital sign, and to look for any fever, hypotension, tachycardia, and tachypneic. And also we need to look for extra-intestinal signs such as the erythema nodosum and also the pyoderma gangrenosum to rule out the inflammatory bowel disease. Okay, for the abdominal examination, we need to look for is there any abdominal distension that can occur due to malabsorption syndrome or small bowel bacterial overgrowth. We also need to assess any abdominal tenderness to look for the inflammation, any fecal mass due to the constipation, or any bowel mass due to inflammatory bowel disease. So we also need to look at we need to do the perianal examination to look at the skin tag or any anal fissure. And we can also look at the stool itself. Is there any presence of the blood in the stool? Okay, next. So these are the hydration status assessment. I bet all of you already master regarding this. Okay, next. So move on to the investigation for the chronic diarrhea. So for the blood investigation, we can do the full blood count to look for any evidence of anemia that can occur due to inflammatory bowel disease or other chronic illness. We also need to look for any increase in the white blood cell count due to the infection or any thrombocytosis that might suggest for inflammatory bowel disease. We can also do the liver function test to look for hypoalbuminemia in inflammatory bowel disease, do ESR because ESR can raise in the inflammation due to the inflammatory bowel disease. And we also need to look for the urea and electrolyte to assess the dehydration status. Okay. Next is the stool examination. So for the investigations of the stool, it is important for us to look for the pH of the stools, electrolytes, and also the osmolarity of the stools. This is important for us to differentiate between the osmotic diarrhea and also the secretory diarrhea because we need to know regarding the osmotic gap. So the stool osmotic gap the formula of the stool osmotic gap is the 219 minus the estimated stool osmolarity. So in osmotic diarrhea, the stool osmotic gap should be more than 100, but in secretory diarrhea, the stool osmotic gap should be less than 50. And the pH for the osmotic diarrhea usually less than 6, and for the secretory diarrhea, it should be 6 or more. For the stool examination also, we can do the culture for bacteria and do microscopy for parasitic ova and cysts to rule out any infectious causes. We also look for any presence of the reducing substance in the stool, such as the glucose, lactose, and fructose. And if there is presence of the reducing substance, it can suggest the carbohydrate malabsorption. We also need to do fecal occult blood to look for the inflammation, and the fecal calprotectin and lactoferrin can increase in intestinal inflammation. So it is useful to distinguish between the inflammatory and non-inflammatory causes of the chronic diarrhea. Okay, next. So for other investigation that we can do are contrast study to look for congenital malformation and look for the signs of motility disorder. We can also do CT scans of the abdomen and MRI, and due to the presence of, to look for any presence of disease of the small bowel, colon, and other internal organ. We can also do colonoscopy to localize the area involved in inflammatory bowel disease and get biopsy. And we also can do barium follow-through to visualize the small bowel involvement. Okay, next. The last part for the chronic diarrhea is the management. So there are 3 principles of the management in the chronic diarrhea, which are the initial resuscitation, nutritional assessment and rehabilitation, and also the pharmacology therapy. So for the initial resuscitation, we need to correct the fluids, and we need to correct is there any fluid and electrolyte abnormalities, any hypoglycemia, and prevent the hypothermia. We also need to identify and treat the underlying causes. If the causes for the chronic diarrhea occur due to the bacteria, so we need to give the antibiotic. If occur due to the parasite, we can give antiparasitic. And usually the chronic diarrhea, we need to refer to the specialist. And for the nutritional assessment and rehabilitation, we need to identify the potentially harmful nutrients and avoid the food that can cause the problem. So for example, in lactose intolerance, we can advise the parents to start lactose-free diets. And if the diarrhea persists, we need to do bowel rest or give parenteral nutrition and gradual introductions of the feeding. And in toddler diarrhea or functional diarrhea, we need to do the 4F principles, reduce the fructose and the fluid, but increase in the fat and the fiber. And we also can consider the enteral, such as the nasogastric tube and gastrotomy tube, or parenteral nutrition if the oral is failed, and give the supplement for the micronutrients and vitamin, such as iron, vitamin A, thiamine, and phosphate. And for the pharmacological therapy, for we can give antimicrobial treatment, immunosuppressive agent if it involves autoimmune enteropathy and inflammatory bowel disease, give anti-secretory agent or adsorbent, which is the Smecta. Okay, I think that's all from me. Thank you.
Okay, I just want to add, the chronic diarrhea, it's more of the growth and development, growth, it means that the growth, including the sign evidence of malnutrition, evidence of height, very important. This part of the not much on the hydration status. Dengar? Okay. Any other questions? Okay, good. Simple and concise. That's all. Simple and concise supaya you all boleh faham. But detail sangat orang tak faham. Okay, next.
Okay, Assalamualaikum warahmatullahi wabarakatuh. So,
Fatimah, ya. Cari nama you dulu. Fatimah binti Muhammad Noor. Okay.
Okay. So I will proceed the presentation with the topic of chronic constipation. Next.
Lah, suara you tak jelas.
Hello. Is it better now?
Boleh lah.
Okay. Okay. So first
Okay
of all,
lah.
I will proceed with the definition of chronic diarrhea. So in the Nelson textbook of pediatrics, it defines constipation. It defines constipation as the delay or difficulty in defecation, which is present for more than 1 month and significant enough to cause distress in the patient. Okay, and then the illustrated textbook of pediatrics defines chronic constipation as infrequent passage of dry, hardened feces, and it is often accompanied by straining or pain and bleeding associated with hard stools. Okay, next. Okay, so this is the Bristol stool chart, and it can act as a guide to help parents tell you the appearance of the child's stool. Next. Okay, so next we continue with the etiology of chronic constipation. So it can be divided into either functional constipation or organic constipation. Okay, so functional constipation is also known as idiopathic constipation, and it can be differentiated from organic constipation with careful history and physical examination. Organic constipation can be further divided due to anatomical cause, due to defect in the intestinal nerve or muscle abnormalities, such as Hirschsprung's disease, due to drugs, due to any metabolic disorders or intestinal disorders. Next. So first of all, we go into functional constipation. Next. Okay. So to diagnose functional constipation, we can use the Rome 4 diagnostic criteria. And this criteria divides the diagnostic categories into children less than 4 years of age and older children more than 4 years of age. So as you can see in the first column, so this lists out the criteria to diagnose functional constipation in children less than 4 years of age, in which they will have to have 2 or more symptoms for at least 1 month. So for the first symptom is 2 or less defecation with sleep, history of excessive stool retention, history of hard or painful bowel movement, history of large diameter stool, the presence of a large fecal mass in the rectum, 1 or more episode of incontinence after toilet training, and the history of large diameter stool that may clog the toilet. Okay, and then for the second column, in children more than 4 years of age, so they will either have to have 2 or more symptoms for more than 1 week, or 1 symptom for more than 1 month. So for the first symptom is 2 or less defecation in the toilet per week, 1 or more episode of fecal incontinence per week, history of retentive posturing, and we'll see after this what does it mean by retentive posturing, history of painful or hard bowel movement, the presence of a large fecal mass in the rectum, a history of large diameter stool that may clog the toilet, and symptoms can be explained by another medical condition. Okay, next. So briefly into the pathophysiology of functional constipation. So usually the chronic cause of functional constipation is preceded by an acute stressor. Okay, so this stressor could be, for example, initiation of toilet training, the birth of a sibling, when the child is starting daycare, or maybe even due to abuse or change in diet. Okay, so due to these stressors, the child will withhold the stool, and this can be intentional or subconscious. Okay. So withholding of the stool will lead to prolonged fecal stasis in the colon and reabsorption of fluid. So this will cause the stool to become harder and larger and more painful to pass, leading to painful defecation. So to avoid the pain, the child will further voluntarily withhold the feces, and this will cause more pain. And over time, when the rectum stretches to accommodate the retained fecal mass, the rectal sensation will decrease and the fecal incontinence may develop, and this will lead to a vicious cycle. Okay, next. Okay, so for the clinical manifestation of chronic constipation, so first of all, we can see that the child may adopt a retentive position. So, okay, after this, I will explain with the aid of a diagram what this means by retentive position. And there may be a history of blood in the stool with passage of large bowel movement. And also daytime encopresis is also common. So encopresis is defined as a voluntary or involuntary passage of feces into appropriate places, inappropriate places. And this has to happen at least once a month for 3 consecutive months. And the child has to reach at least a developmental age of 4 years old. And it is important to note that encopresis is not diarrhea and also not due to another substance such as laxative or underlying medical illness. Next. Okay, so this is what I mentioned earlier by retentive position. As you can see here, all 3 of the children are standing. So they are holding onto furniture while standing, or the child may be lying down and contracting the gluteal muscle by stiffening the legs, or the child may also be squatting quietly in the corners while waiting for the urge to defecate to pass. And as the rectum accommodates the content, so the urge to defecate will pass. And usually this kind of position, they may be mistaken by the caregivers as an action of straining. But actually it is the child withholding the urge to defecate. Okay, next. Okay, so for the treatment of functional constipation, so first of all, it is important to educate the patient and the caregiver and to tell the parents that the soiling is not a willful act, but actually it is actually something related to do with overflow incontinence. Okay. And also important to advise the patient, the parents not to respond to the soiling with retaliation or punitive behavior because the child may become angry, ashamed, and resistant to any form of intervention. Okay, and then if the child continues with impacted stool, then it is important that we try to bring relief by giving rectal enema, and also once the constipated stool has been evacuated, then we need to maintain by giving stool softener such as laxative, and also we need to encourage the patient to regularly toilet train the child. And also to adopt a balanced diet which has adequate fiber and intake of fluid. Okay, next. Okay. Then we go to the second category of constipation, which is organic constipation. And here I would like to focus on H-Strong disease. Next. Okay. So the definition of H-Strong disease, it is a developmental disorder of the enteric nervous system characterized by the congenital absence of ganglion cells in the submucosa and the myenteric plexus. And this is the most common cause of lower intestinal obstruction in neonates, however not very common in preterm babies. And Hirschsprung disease can also be associated with other congenital defects such as trisomy 21 and also conditions such as microcephaly, mental retardation, abnormal faces, and cleft palate. Okay, next. So briefly into the pathology of Hirschsprung disease. So as we know, as I explained earlier, Hirschsprung disease because there is the absence of ganglion cells in the wall of the colon. Okay, so it's extending from the rectum proximally. So this is the result of the arrest of neuroblast migration from the proximal to the distal bowel. Okay. So when there is the absence of neural innervation, there will be inadequate relaxation of the bowel wall, resulting in the bowel wall hypertonicity. Okay, and this can further lead to intestinal obstruction. And usually the aganglionic segment is mostly confined to the rectosigmoid. However, it can also be proximal to the sigmoid in a minority of the cases. Okay, next. Okay, so for the clinical manifestation of Hirschsprung disease, usually it is diagnosed in the neonatal period. So we can see that the baby has a distended abdomen, okay, and failure to pass meconium in the first 48 hours of life. And there may also be bilious vomiting and feeding intolerance. And if sometimes neonates, they can pass meconium directly normally. However, when they get older, they will have a history of chronic constipation. And the child also may have failure to thrive. And also in severe cases, there may be enterocolitis. Because when there is intestinal obstruction, so there is dilation of the bowel proximal to the obstruction. So, and also the faces of the stool can lead to proliferation of bacteria. So this can lead to enterocolitis. And you can see that the child may present with diarrhea, abdominal tenderness, sepsis, and bowel obstruction. And when you perform physical examination, there may be a large fecal mass that is palpable in the left lower abdomen. And when you do the per-rectal examination, usually the rectum is empty of feces, but when you remove your finger, there will be explosive discharge of foul-smelling feces accompanied by gas. Next. Okay. So for the gold standard of diagnosing Hirschsprung disease, it is a rectal biopsy. And upon biopsy, we can see a large number of hypertrophic nerve bundles that stain positively for acetylcholinesterase with the absence of ganglion cells. And when you do anorectal manometry, the internal anal sphincter can also fail to relax when you distend the rectum. Okay. And then barium, you can also do contrast imaging, such as using barium enema. So next. Okay, so this is an example of a barium enema of an infant with Hirschsprung disease. So as indicated by the yellow arrow, you can see there is the transition zone between the lower segment of the colon, which has no ganglion, and the proximal part of the colon, which is normal. Okay, next. So the management of Hirschsprung disease is surgery, in which there needs to be removal of the segment of the colon which is affected, and temporary stoma can also be delayed when the child is older. And we need to do primary pull-through procedure in patients with Hirschsprung disease, in which when the affected colon is removed, so there will be anastomosis between the section of the normal bowel with the rectum. Okay. Okay, so this is a table. You can look at it later. So it tells you the features which differentiate between Hirschsprung disease and functional constipation. Next. Okay. Next we go to the approach to chronic constipation. Okay. Okay. So in history taking, it is important first of all to ask the parents about the delayed passage of meconium, because usually normal babies, they can pass meconium within 48 hours of life. So if there is no passage of meconium, then we need to think of Hirschsprung disease. So furthermore, about the onset, you ask whether the constipation was present from birth or early infancy, because this is more likely to be due to an organic cause. However, for functional constipation, we also need to ask whether there was preceded by an acute stressor, such as any changes in the diet, whether the onset is the same as toilet training, or there is any problem with the toilet training, or if the child is starting daycare. Next. Okay, so next we also need to ask about the stool quality and appearance. So ask if there is any painful defecation and any hard stool, and if there's the stool clog the toilet, because this will likely indicate functional constipation. And then ask also any presence of blood, because we need to rule out any possible anal fissures. And then also ask previous history of soiling or accidents in the underwear, because this can be due to fecal incontinence, secondary to functional constipation. Next. Okay, and then ask the dietary history. So we need to ask if the sources of fiber and fluid are adequate, because this can lead to functional constipation, or if there are any changes in diet, or if the child has any underlying medical problems, any congenital anomalies, any abnormal growth or developmental delay, because other causes of constipation also include congenital malformations, spinal abnormalities, which can interfere with the secretion. Next. Okay, so these are the red flags that we need to be alert of if a child presents with constipation. Next. Okay, so upon physical examination.
Go back. Baca sikit.
Okay. So among the red flag symptoms and signs that we need to observe, number one, failure to pass meconium within the 48 hours of life. Okay, we need to be aware of Hirschsprung disease, and if there is any faltering growth or failure of growth, because we need to suspect hypothyroidism or celiac disease. Any abdominal distension, which can indicate intestinal obstruction in Hertzsprung disease. If there is any lower limb, abnormal lower limb neurology or deformity, then you need to suspect lumbosacral pathology. And then inspect the back also, so any sacral dimples and any hairy patches, any central state or skin discoloration, to look for spina bifida occlusa. And then also inspect the anus for patency, any abnormal appearance, and the positioning, because there may be abnormal anorectal anatomy. And also when you inspect the perianal region, look for bruising or multiple fissures, because this can be due to sexual abuse. Okay, and then at the same time, look also for any presence of fistula, abscesses, or fissures, because you need to suspect chronic disease. Okay. Okay, and then the physical examination. So generally, you need to see if the child has failure to thrive, if the child has syndrome, any signs of nutritional deficiency such as fatigue, any dysmorphic features which may indicate Down syndrome, if the child is febrile or dehydrated, because as we know, enterocolitis is a complication of Hertzsprung disease, any retentive posturing such as explained earlier, and any abnormalities in the lower limb, hypotonia, atrophy, because we need to also suspect hypothyroidism or any spinal pathology. Next. Okay, so when you look at the abdomen, you need to look for abdominal distension, and also palpate the abdomen because there may be a palpable stool mass in the left quadrant, and also any masses in the suprapubic area, any cutaneous changes in the lumbosacral area, such as explained earlier, any suggestion of spinal dysrefusism, and look at the underwear for any soiling to indicate fecal incontinence, because this may suggest functional constipation, and also do the anal wink and cremasteric reflex, because we need to also rule out neurologic dysfunction. And as I said earlier, look for any presence of fissures, any scarring, okay? And also look for the any displacement of the anus or any perianal fistula. Okay. It is also important to complete your examination by doing a digital rectal examination. So first of all, you want to look at the tone of the inner sphincter. So increased tone may be suggestive of Hertzsprung disease. But if there is hypotonicity, then you may want to suspect neurogenic causes. And also look at the size of the rectal wall, because in a large wall, this is consistent with chronic functional constipation due to withholding of the feces. If there is any impacted stool, and if there is the stool hard or soft, and when you remove your finger, look for any explosive expulsion of the stool, because this can be related to Hertzsprung disease. Next. Okay. So investigation. So for the blood investigation, you want to do thyroid function test to rule out hypothyroidism, which is a common cause of constipation. Any linear profile to look for any electrolyte imbalance, because the child may be malnourished. Okay, any NCRT to look for signs of any active infection if the child has acute conditions such as enterocolitis. And then also the imaging. So you want to do an abdominal X-ray to look for signs of intestinal obstruction, barium enema to rule out Hertzsprung disease, like the picture I showed earlier, and also spinal X-ray, because we want to look at any spinal pathology, which may also cause a defect in fecal emptying. And also rectal biopsy, if strongly suggestive of Hertzsprung disease, then you want to do a confirmatory diagnosis by doing a rectal biopsy. Next. Okay, next.
Tak payah, proceed. Okay.
So for the management of constipation, so first of all, it is important to focus on toilet training and avoid voluntary withholding. So we need to educate the patient by regularly telling the child to switch to toilet sitting after meal. And when the child adopts a positive bowel habit, then it is important to give positive reinforcement, so the behavior is reinforced. Okay. And then when the child presents with infection, then we need to evacuate the rectum by giving enema and laxatives such as lactulose, polyethylene glycol, bisacodyl. And eventually, when the constipation is
resolved, then we can taper down the dose. And also dietary intervention is also important by enhancing on a balanced diet, which is rich in fiber and sufficient fluid. And that is all for chronic constipation.
Tak payah, tak payah.
Okay.
Don't waste time. Okay. Okay, next. One I know.
Yes. Can you hear me?
Mana one
Okay.
I know.
Okay, so I'll proceed the presentation with topic liver failure in children. Okay, next. Okay, so for liver failure topic, I divided it into two, which are the acute liver failure and also chronic liver failure. So I present first, starting from the acute liver failure. Next. Okay, first for the definition of acute liver failure, the pediatric acute liver failure study group define the acute liver failure as when there is evidence of acute liver injury with no known evidence of chronic liver disease and when there is presence of hepatic base coagulopathy. What is meant by hepatic base coagulopathy is that when there is PT time is more or equal to 20 seconds, or when the INR is more or equal to 2, and that is not corrected by the parenteral vitamin K regardless of the presence of hepatic encephalopathy. Or when there is presence of hepatic encephalopathy, the PT time is more than 15 seconds or the INR is more than 1.5. Okay, next. However, based on the Sunflower textbook, the definition of acute liver failure is when there is development of massive hepatic necrosis with subsequent loss of liver function with or without hepatic encephalopathy. And from the essential textbook, it described it as a severe liver disease with onset of hepatic encephalopathy within 8 weeks after the initial symptom in the absence of chronic liver disease. Okay, next. Okay, moving on to the etiology of the acute liver failure. Based on the textbook and also protocol, it can be divided into few causes, which are the more than 45% is due to the indeterminate cause, and followed by the infectious causes, metabolic causes, drug and toxin, vascular and also ischemic, autoimmune and also malignancy. So I go one by one. However, in the textbook, it stated that the two most common causes is what I star there, which are the infectious causes and also the metabolic causes. For the infectious causes, viral hepatitis, which include the hepatitis A, B, and also E, is the most common cause of the liver failure. For the hepatitis A, it is spread by the fecal oral transmission and it is self-limiting. However, for the hepatitis B, it can cause both the acute liver failure and also the chronic liver failure. And it spread in pediatric, it spread by the vertical transmission from the carrier mother to the child. And there will be presence of features of acute hepatitis such as jaundice, nausea, vomiting, abdominal pain, lethargy, and other virus as listed below. The next etiology is the metabolic causes such as the neonatal hemochromatosis, Wilson disease. Wilson disease also can cause both acute and also chronic liver failure. Others like alpha-1 antitrypsin deficiency, galactosemia, and others. Noted also other etiology such as drug, for example, the paracetamol, some of the anti-epileptic drug and also some of the antibiotic can cause also acute liver failure. Okay, next. Okay, other like I mentioned just now, the vascular or ischemic causes, the autoimmune such as autoimmune hepatitis and the malignancy such as the acute leukemia and also lymphoma. Next. Okay, so moving on to the clinical features of acute liver failure. the child may present with the persistent or prolonged jaundice, which occur more than 14 days, together with the impalpable liver or reduced in the liver size. Next. They also may be presented with encephalopathy, which may worsen quickly, in which they will present with increase in lethargy or occasional hallucination. And this usually detected by the relative, in which they notice that the child become having personality changes, such as become more irritable, become more aggression in older children, and they also may present to some extent to the intellectual deterioration, insomnia, and also having the sleep reverse pattern. Next. The other clinical features which include bruising, decay, or bleeding. Okay, this is because, as we know, the liver is producing the clotting factor. However, when there is a liver failure, this clotting factor cannot be produced, so it will lead to manifestation of bruising, decay, and also bleeding. Next, clinical features is that they have failure to maintain the normal glycemia. This is because, as we know, the gluconeogenesis occur in the liver. However, if the liver is failed to do the gluconeogenesis, it will lead to the hypoglycemia. And they also may present, some also may present with the increase of the ICP sign, such as the dilated pupil, bradycardia, hypertension, or papillary edema. This is because of the complication of the cerebral edema. Okay, next. Okay, moving on to the history. What we need to ask actually is according to the presentation of the child. For example, if the patient usually they will presented with jaundice, so we need to ask more about the onset, the progression, the duration of the jaundice, and for the hepatic encephalopathy, we can ask if there is any irritable or in the younger children, they can present with poor feeding, or in the late presentation, they can have confusion or aggressive behavior. And also ask for the abdominal extension to rule out the ascites, the bleeding tendencies features such as the bruises, decay, and also bleeding, the hyperglycemic symptoms such as lethargy, tremor, sweating, and also vomiting. And also don't forget to ask also to rule out the infection, which is one of the causes of the acute liver failure. We can ask about the fever, any rash, any vomiting, any history of sick contact, and history of eating the contaminated food. Okay, next. Okay. Other history also, we can ask the drug history, because one of the causes of acute liver failure is the drug and toxin also. Any over-the-counter drug, any alternative or herbal medication. Next is regarding the past medical history. Any previous episode before, any history of blood transfusion. Next, regarding the family history, some of the disease such as Wilson disease is inherited in the family. And ask also about the growth and also the developmental history of the child. Next. Okay, for the physical examination, what we want to look for from the general, first we look for the GCS level of the children, and then look for any peripheral edema or any shock. And for eyes, we can look for the any scleral jaundice or any facial ring, which can contribute to the diagnosis of Wilson disease. For the abdominal examination, we can, for the liver and spleen, look for any hepatomegaly or any splenomegaly, or any rapid decrease in the liver size without improvement is a very bad sign. Okay, next for the ascites, look for shifting dullness and fluid drift. And for the skin, look for any bleeding tendencies such as bruises, petechiae, and also bleeding. Okay, next. Okay, for the investigation, I divided it into bedside investigation, lab investigation, imaging, and also others. For the bedside investigation, we can do a blood glucose level to look if there is any evidence of hypoglycemia. For the full blood count, we can look for any presence of thrombocytopenia. For the liver function test, we look for any risk in liver enzyme such as AST, ALT, and also ALT. and also any evidence of hypoalbuminemia as liver, as when there is a liver failure also, it cannot produce the albumin, which cause the hypoalbuminemia. So next, for the coagulation profile, it can presented with prolonged PT, APTT, and also INR. The renal profile, look for any electrolyte disturbance. We can also do plasma ammonia and also virus serology such as hepatitis A IgM, hepatitis B surface antigen, and also for the virus serology. Okay, next for the imaging, we can do ultrasound of the liver to check for any ascites, any flow of the hepatic vessel, and check for the portal veins. And we can also do CT brain to rule out the cerebral edema, which is one of the complications of the liver failure also. The others we can do EEG, and based on the textbook, it's stated that some the EEG, the electroencephalogram, some show the acute hepatic encephalopathy evidence, and other invasive investigation, we can also do liver biopsy. Okay, next. Okay, so for the treatment of the acute liver failure, it is mainly the supportive, and the definitive treatment is basically the liver transplant. Okay, next. Okay, what I mean by the supportive therapy is that, we give the treatment based on what the patient presented. For example, if the child presented with a hepatic encephalopathy, the treatment is we avoid the sedative, we give like Tulos, and if the patient presented with coagulopathy, we can give FFP or platelet transfusion. And if the patient presented with hypoglycemia, we can give IV glucose. And when there is ascites, we restrict the fluid and also sodium intake. And
Apa?
okay, next slide. Okay, this is the criteria for the
Forget it.
like I said. Okay.
Forget it.
Okay.
Tak ada exam you pun.
Okay, so that's all for the acute liver failure. So moving on to the chronic liver failure. So the definition is that it is characterized by the development of cirrhosis and its complication, and by the progressive hepatic failure. Okay, next. Okay, for the etiology or the causes of the chronic liver failure, the causative condition can be divided into congenital or acquired. For the major congenital disorder that leads to chronic liver disease include the biliary atresia, which is the bile outlet obstruction, in which liver cannot secrete the bile to the duodenum, which cause the reflux to the liver bag and cause damage to the hepatocyte. Others like thalassemia, untreated galactosemia, and alpha-1 antitrypsin deficiency. In older children, the causes is mainly due to the hepatitis B or hepatitis C, and others can be due to autoimmune hepatitis, Wilson disease, PSC, cystic fibrosis, and also biliary obstruction secondary to cholelithiasis. Next. Okay, so for the clinical features of the chronic liver failure, so the patient is presented with hepatomegaly or ascites, cirrhosis, the dilated vein, which we call the medusa, which is due to the portal hypertension, which is secondary to the cirrhosis of the liver. Okay, they can also presented with gynecomastia, icterus, trauma erythema, spider nevi, ectonosis, because of the defective in the coagulation, and also niconicia, which is due to the hypoalbuminemia, and also finger clubbing. Some can present also with asparagus and also hepatitis. Next. Okay, so this picture I took from the textbook also. Some from sunflower. Okay, first picture, as you can see, the children presented with distended abdomen, which is from the hepatosplenomegaly and also ascites. And there is also presence of the spontaneous swelling from the ascites. And for the second picture, as you can see, the children had dilated presence of dilated vein which is secondary to the portal hypertension, which is one of the cause, one of the complication of the chronic liver failure. Okay, next. Okay, for the investigation in chronic liver failure, the aim is two. Which the first one, we want to diagnose the underlying illness, and the second one, we want to monitor the status. Okay, in children presenting for the first time with evidence of chronic liver disease, we should have a standard investigation. Okay, next. Okay, what I mean by the standard investigation is that we can do the viral hepatitis, the metabolic testing, the autoimmune hepatitis, or the anatomic evaluation, including the ultrasound, and also to some extent to the liver biopsy. Okay, this the aim is we want to diagnose, we want to know the cause of the chronic liver failure. Okay, next. Okay, the second investigation aim is we want to evaluate the status of the chronic liver failure. We can, same like in acute liver failure, we can do investigation like liver function test, the ultrasound of the liver, the coagulation profile, the blood count, the serum ammonia, and also we can do also the diagnostic paracentesis, because the patient also can have a spontaneous bacterial peritonitis, which is one of the complications of the ascites from the liver failure. Okay, next. Okay, so for the treatment of chronic liver failure, the management is complex and require the multidisciplinary approach. However, we can treat the child according to the problem what the child presented. For example, if the patient presented with gastrointestinal variability secondary to the portal hypertension, we can give the somatostatin infusion, the non-selective beta blockers such as propranolol. We can do band ligation and also sclerotherapy. For if the patient presented with ascites, we can restrict the sodium and also fluid intake, and we can also give vitamin supplement, because as we know, when there is a liver failure, the fat soluble vitamin such as vitamin A, D, E, and K is deteriorate, so we can give the supplement, vitamin supplement. And the last, if the patient presented with hepatic encephalopathy, we can give lactulose or enema if the patient is constipated. Okay. I think that's all from me.
Okay, next.
Okay, Bismillahirrahmanirrahim. So my name is Nopara Nabila. I'll be the last presenter. So my topic will be Nopara Nabila. So my topic will be functional abdominal pain. Okay, so basically, next, hello. Okay. Functional abdominal pain syndromes. So it basically it is a persistent stomach pain that is lacking objective evidence for organic pathology. So it is a chronic abdominal pain but poorly related to gut functions, and it is a refer pains. It is a refer to pains without evidence of anatomy or inflammatory metabolic or neplastic abnormalities. And based on what I have found in a journal, it mentions that functional abdominal pain, they have a highest comorbidity with psychiatric disorder. Okay, so how to differentiate between recurrent abdominal pain and functional abdominal pain is that abdominal pain, they have relations to organic and non-organic cause. But if the recurrent abdominal pain are not associated with any pathologic cause, so the condition can be renamed to functional abdominal pain syndrome. Next. Functional abdominal pain syndromes can be diagnosed based on Rome 4 criteria. So the criteria must be fulfilled at least 2 months of at least 4 times per month, and including all the following. So in criteria A, there's an episodic or continuous abdominal pain that does not occur solely during physiological events such as eating and menses. In criteria B, insufficient criteria for other functional GI disorder, including irritable bowel syndromes, functional dyspepsia, or abdominal migraine. And in criteria C, after appropriate evaluations, the abdominal pain cannot be fully explained by other medical condition. Okay, a little bit on the functional abdominal pain. So basically, there are two. Pathophysiology behind FAPs is complex and not understood, but they involve the enteric nervous system and also the central nervous system. So there are two pathways, which is the first one is brain gut axis dysregulations. So from this, they have the inability to turn down the pain signals. So with the abnormal reaction to the stimuli, such as any stressful event or psychological stimuli, even with the small amount of stimuli will amplify the severity of the pain. And the second one is because of visual hypersensitivity. This could be due to the abnormal interpretations of normal signals by the brain or aberrant signals sent to the brain, or it can be both. So from that, even the normal stimuli may be perceived as a severe pain, as a pain. Okay.
Pusing balik backward. Tak dengar sangat lah Farah. Depan balik. Forward. You dengar tak presentation dia? You dapat dengar tak Farah ni presentation?
Dengar tak?
Ha?
Kan aku start weh.
Ada dengar, ada hilang kan?
Dia dekat tiba-tiba hilang pasal ada balik.
Ada hilang, ada ni, ada hilang.
Alamak.
Alamak,
sorry,
alamak.
I think there's a unstable connection here.
Kat mana?
I'm right now in Mahala. So I use Mahala punya Wi-Fi. Kat mana tadi yang termiss tadi?
Tak apalah. Yang ni penting. Classification dia. Pisang dia low. Elan tak penting.
Okay.
Okay. Classification.
Okay, so classifications of functional gastrointestinal disorder. So based on room 4 criteria, they divided into 4. First, irritable bowel syndrome, functional dyspepsia, abdominal migraine, and functional abdominal pain. Okay, next. Okay, so this is the diagnostic criteria for different groups of abdominal pain-related functional gastrointestinal disorder. So to make up functional abdominal pain as a diagnosis, so we need to exclude these three other abdominal pain. Other functional gastrointestinal disorder. So the first one is functional dyspepsia. Okay. In functional dyspepsia, they have at least 2 months for at least 4 days per month of one or more of the following. The first one, postprandial fullness. Second, early satiations. Third, epigastric pain or burning not associated with defecation. And the fourth one is after appropriate evaluation, the symptoms cannot be fully explained by other medical condition. Next is irritable bowel syndrome. Must include of the following. The first one is the abdominal pain, at least 4 days per month associated with one of more of the following, which is the related with defecation, change in frequency of stool, change in stool form or appearance. And in second criteria, the children with constipations, the abdominal pain does not resolve with the resolutions of the constipation. And the third criteria, after appropriate evaluation, the symptoms cannot be fully explained by other medical condition. And the last one, about the abdominal migraine. Okay, the criteria must include all the following occurring at least twice. Okay, in criteria, in first one, paroxysmal episode of intense acute periumbilical midline or diffuse pain that lasts for 1 hour or more. The second one, episodes are separated by weeks to months. The one, the pain is incapacitating and interferes with normal activities. The fourth one, stereotypical patterns and symptoms in the individual patients. The fifth one, the pain is associated with 2 or more of the following: anorexia, nausea, vomiting, headache, photophobia, or pallor. And the last one, after appropriate evaluation, the symptoms cannot be fully explained by other medical conditions. Do you hear my voice? Okay. Hello? Hello?
Okay, apa tu? Ha?
Okay, dengar.
Hello? Ha, dengar.
Okay, so next. To approach patients with functional abdominal pain syndromes. So basically, patients came with complaints of pain. So we have to we can use Socrates as to elicit the symptoms. So first, sight. Usually, it is poorly localized, especially in young children, because they often have difficulty to localize and describing the pain. However, in older children, they can often localize pain, even though they may describe the pain to be generalized or can be changed locations. And then for the onset, FAP is a recurrent and chronic, and the pain can be sudden in onset and can be worsening. And for the characteristic of the pain, patient will complain as a dull or crampy, bloating, and they can also they may describe also the pain as agonizing and sickening. However, if patient complain the pain as sharp or severe pain, so we must suspect pathology cause first. And for the radiations, usually there's no radiation. And for relieving factors, usually it's resolved spontaneously. And for the time, there's no specific durations of symptoms. The pain. And for aggravating factor, usually due to stress, can be due to relations to past surgery or trauma and food relations. This is because of the oversensitive bowel. And for the severity, usually it worsening at morning, which prevent or delay child from going to schools. And not to forget the associated symptoms such as nausea, vomiting, reflux, diarrhea, and constipation, and so on. Okay, next. Okay, so from the physical examination, so what we can elicit is that from the general examination, we can look for the signs of complications such as malnutrition of anemia, because sometimes patients that have a chronic pain, they tend to develop loss of appetite. So they don't want to eat, and so that's how patients tend to get malnutrition or anemia. Not to forget the anthropometric measure also. Usually they tend to have a loss of weight. And for the abdominal examinations, there will be diffuse abdominal tenderness, otherwise normal. Okay, next. Okay, this is red flags. So basically, we need to elicit also the alarm signs and symptoms, because of if a patient presented with these red flag symptoms and signs, usually they need further investigations, and the management will be different. So examples, red flag symptoms is that patient might presented with blood stool, persistent vomiting, dysphagia, and odinophagia, and so on. Okay, next. Okay, this is examples of alarm signs such as hepatomegaly, splenomegaly, localized fullness. There's mass, there's jaundice, and so on. Okay, next. So what's
Dia balik backward. Backward. Backward, backward. Forward. Ke depan. Backward. Ke belakang. Okay, stop. Baca satu-satu. Pay that which up. Baca.
Okay. Okay, so the alarm symptoms usually need further investigation is the first one is pain that wakes up the children from sleep, persistent right upper or right lower quadrant pain, significant vomiting, such as bilious vomiting, protected vomiting, cyclical vomiting, worrisome patterns to the physicians, unexplained fever, genitourinary tract symptoms, dysphagia, odinophagia, chronic severe diarrhea or nocturnal diarrhea, gastrointestinal blood loss, involuntary weight loss, decelerations of linear growth, delayed puberty, and last one is family history of inflammatory bowel disease, celiac disease, or peptic ulcer disease.
Forward. Baca.
And for the alarm signs, examples is that localized tenderness in the right upper quadrant, tenderness in the right lower quadrant, localized fullness or there's mass, hepatomegaly, splenomegaly, jaundice, coastal vertebral angle tenderness, arthritis. They can also be presented with spinal tenderness, perianal disease, abnormal or unexplained physical findings, hematochezia, as well as anemia.
Okay.
So next about the differential diagnosis. So this is examples of differential diagnosis that can be made other which also need to be excluded during history taking and examination as well as investigation in order to make functional abdominal pain syndromes as a diagnosis. Okay, it can be chronic constipations, there's a peptic ulcer disease, celiac disease, lactose intolerance, parasitic infections such as giardiasis, inflammatory bowel disease, esophagitis, recurrent interceptions, and lastly chronic appendicitis. So next. Okay, again, this is another examples of the...
Forward.
Okay, next. Okay, so how we want to approach patients with functional abdominal pain syndromes is first from the history itself, they complain chronic abdominal pain, and then make sure there's no red or warning signs and symptoms. And for the physical examination, usually normal except that there's a generalized tender at the abdomen. And for the investigation, usually the result will be normal. So from that, functional abdominal pain can be made. Okay, next. Okay, so these tables actually they tell about examples of evaluation that can be done for the patients who complains of recurrent abdominal pain. So first, of course, need of a complete history and physical examination, and then don't forget about the warning sign. Also, we need to determine the functional impairment such as missing school, especially in the children. Okay, and for the investigation, we can
You malas sangat nak tulis. You cut the paste je. Forget about it. Forward.
Okay. Okay, next.
Okay.
Okay, next about the management. So basically the aim is to reduce the suffering and improve overall quality of life. So we use biopsychosocial approach. So we do reassurance and education, psychotherapy, dietary, and last one is pharmacotherapy. Before we approach to this, before we approach to this management, so it is important for us to make a correct diagnosis because the specific cause of the pain have a different management. So, okay, specific to functional abdominal pain syndrome management. So first is reassurance and educate. So basically, we need to validate the symptoms that the pain is real, but it is not dangerous and not related with underlying disease lah. And then we also need to educate patients that because of pain is not serious, so they can have they can return back to the regular activity. They can go to school, and also not to forget to have a close followings and counseling. And then we can do we also can do some lab tests if needed in reassurance, especially for the parents lah. Okay, next. Okay, as I've been mentioned before that FAPs have a comorbidities with psychiatric illness. So if there's identified psychiatric illness, so we need to refer to the psychiatrist. Usually, the approach that been done in, sorry.
Oh, you tak buat benda-benda tu, mengarut lah.
Okay.
Baca je cukup.
Because okay. Because this I get from the NCBI, so they mentioned that.
Ya, you tak keluar dari exam you pun detail sangat. Hipnoterapi, dia keluar MCQ macam tu. You buat simple je, you punya management. Apa dia buat susah? Your student saja, bukannya master student.
Okay.
Kenapa nak susah diri belajar benda yang susah-susah tu? Lepas tu you complain kita orang banyak benda nak belajar. Benda yang tak sepatutnya you belajar, you nak belajar. You find you student, medical student, you don't need to know everything. You only need to know what's important saja. The three just fiber added food ni apa tu? Ini food mat. Itu I tahu apa benda food mat ni. Buat special dietary punya ni. The probiotic supplements itu sajalah. I memang tak suka kalau you dwell sangat dalam management. No, because it's not your level. Baca probiotic supplement tu.
Okay, so for probiotic supplement, this again I get from the NCBI. So it is important to give because probiotic supplement can enhance the gut barrier function, and also it can inhibit pathogen to bind and inhibit the growth of other pathogenic organisms, and from that it can modulate the gut's inflammatory response. And also because of the visceral hypersensitivity is one of the pathophysiology for the FAP. So by giving probiotic supplement, it can reduce the visceral hypersensitivity associated with both inflammations and psychological stress. And last one, it also altering the colonic fermentations by converting undigested carbohydrate and improve the gut function.
Okay, for what?
Okay. Next, pharmacotherapy. I think this one, yeah.
Don't waste time.
Okay.
For what?
Okay, the last one. One is the prognosis. So usually, functional abdominal pain syndrome is self-limiting, so it can improve by the time, and most children will be able to grow out of it lah. Okay, I think that's all for my part.
Apa? Okay. Menyusahkan diri. Okay. Ada apa lagi? Any more? Habis?
Dah habis.
Okay, finish. Selalu dapati beberapa student bila come tu dia over present kadang-kadang. Suka nak present benda yang terlalu difficult. Difficult dalam case the functional is very difficult things to handle. Usually we refer to the pada apa tu pada GI specialist. Okay, finish.
Dah habis juga, guys.
Thank you.
Okay, thank you.
Tutup majlis guys.